Hello.
Jay Kumar, welcome Vijay.
Hello, sir.
Yeah, yesterday was nice. Yesterday, or day for yesterday, Ambedkar was day for yesterday.
Day for yesterday, sir.
Yeah,
And Friday is Surjit Singh.
Vijay Singh. Yeah, I know.
Yeah. Hello.
Yeah, no, that's going fine. Your first talk by Rajesh, the neonatologist, was the pediatric neurologist, on neonatal seizures, was a beautiful.
Yes, sir.
Excellent. He just went through it like a real, what masterclass it was.
Yes, sir.
Lovely.
I think today also we are waiting for almost same thing.
Yeah, today we'll have Dr. Raju and Suma.
Yeah.
Huh?
Yes, sir.
How's Pediatric Companion next one?
Next one is on October.
In October.
Yeah. We got 1 or 2 articles now.
Yeah, you got one from MKC, no?
Yes,
Today?
sir. Today I got it.
Yeah.
Okay. What is MKC written on?
Hello, sir.
What is MKC written?
MKC is, I didn't go through it. I just downloaded it. I want to read it today.
Okay.
So that is something.
Just something.
He's starting the neonatal fellowship in NIMS. And he's starting a nursing fellowship also. International, IAP is growing a fellowship for nurses on neurodevelopment. And he's the pioneer. He's first 2 years, he'll do it only at NIMS. And then we'll in other institutes. So he's joining our IAP neurodevelopment chapter fellowship for pediatricians, has given it an impetus.
This is something related to RBSK. I have not gone through it. I'll see today.
Good.
Some articles.
Yeah, you're getting good articles. What about the putting into the index medicus to?
Yeah, that is actually I had a talk with them. I think we have to meet at least after 1 or 2 weeks. There are some issues are there. I think
IGPP has not been able to do it.
Yes. It is not a very easy job.
Oh, it's very difficult. I think you have to really work on it and improve the standards. There's a lot of. You should have an online for some time. I think you should have online submissions.
Yes. That is one thing. I think we have to have few reviewers. They have to accept it. Then only we can put the article in the journal. That all these things we have to be very meticulously do it. That is the problem.
Online submissions and all have to be very pakka.
Yeah. That is the thing. I think we have to find out some good reviewers and we have to send it to them.
Yeah. And your plagiarism software should be good.
That software we have to buy it. And
you have to buy this software. A lot of work.
Yeah. I think we have to work on it. Anyway, within 1 or 2 years, we have to do it.
Yeah, we have to.
So we'll start in 2 minutes.
Yeah.
Okay, sir. We have to mute it. Mute.
Yeah. Mute.
I think video also is we have to put off.
we'll start.
Yeah, start.
Good evening, everybody. Welcome to another exciting episode of Pediatric Potpourri, brought to you by IAP Cochin Branch in association with IAP Kerala. This is the 8th session in the series of Potpourri we've been doing. And today is a very exciting topic. And we have renowned speakers in the field. Welcome all. Over to Dr. Jason for the conduct. Thank you.
Thank you, Dr. Pramod. You've been doing a great job as president of IAP Cochin Branch in putting this Potpourri going. Now, this is another day of academic activities where there's going to be a lot of educational material that we're going to give you. We have always talked in rheumatology, we always talked about JIA, and that's it. So we thought that we should tell people about what are the problems with children who present with juvenile dermatomyositis. That is a topic which pediatricians don't really know about. PGs, they get a short note, they won't be able to write what actually happens to these children. Now we chose this term rollercoaster. So this rollercoaster as a metaphor has been used previously for various chronic illnesses that start in childhood. For hearing impaired, those who cannot speak well, autism, it's a roller coaster ride for these children. The roller coaster experience is another term that's been used. Roller coaster asthma is a term that has been used earlier. So this is something that parents have felt that juvenile rheumatoid arthritis, parents of children with juvenile rheumatoid arthritis, juvenile dermatomyositis, feel that there's recurring ups and downs in this particular condition. It's like a roller coaster ride. That is why this term was chosen, and that's what we're going to talk about: roller coaster on juvenile dermatomyositis. And so we start this with a case presentation, which will be by Dr. Preetha. Dr. Preetha, can you share your slides, please? Unmute yourself. So yeah. We'll start with start with a case, which will be the reference to on which the other speakers will be speaking, and we'll go through this roller coaster. And I hope you enjoy all that is discussed here, and have a lot of questions in the end, because this is an area which we need to know more and more about. It's something that's not in the purview of pediatricians, but still all of us who need to know what our patients are going to like, because they're going to come back to us for follow-ups. Dr. Preetha, can you share your slide, please? Preeti?
Sir, I'm trying to, yeah.
Yeah. So, Dr. Preeti, next slide, please, is a consultant pediatrician at Lutz Hospital, Pasalam in Cochin. And she is the one who's dealt with this particular case as a few years ago. She did her MBBS at Kottayam Medical College, and the previous slide, and did an MD at Stanley Medical College and a fellowship in neonatology and a PGDN also. She's a was junior consultant in Caritas Hospital, Kottayam for 2 years, then at Paramala Hospital, and now for the last 12 years, she's been at Lutz Hospital as consultant pediatrician. Over to you, Preeti, for the presentation.
Thank you, sir. Before I start, I'd like to thank IAP for giving me this opportunity to present this case. I'm somewhat technically challenged, so please bear any glitches with me. The patient details are as follows. It was a 7-year-old girl child who was referred from ESI hospital. She was one of the non-identical twins of second order of a non-consanguineous marriage, and the information was given by the parents. She was first admitted to our hospital in November 2018. So the presentation of the illness was, she was apparently normal about 1 month before she presented to us, when she developed a generalized photosensitive rash and generalized edema, which was of 1 month duration. And she had weakness and myalgia for about 2 weeks. And the course of the illness was, it started as a periorbital violaceous rash, became generalized, and was associated with severe itching. The rash was photosensitive. They gave her homeopathic treatment for a week. By that time, she had developed generalized edema. And by 2 weeks, she could not perform daily course due to weakness, mostly of a proximal type. And soon she was restricted to bed. And she had generalized body ache by this time, and she was referred from ESI hospital for evaluation around that time. Now, the negative history included that she didn't have dysphagia, dysphonia, or dysarthria, and there was no diurnal variation of weakness. She didn't show any respiratory or GI symptoms. There was no fever, loss of weight, or joint issues. She didn't have visual problems. There's no history of any contact with tuberculosis or any significant illness in the past, and she has had no history of any allergies. The other histories, birth history was essentially normal, and she attained her developmental milestones appropriately. She's immunized for age, dietary intake was appropriate. Family history and pedigree chart did not throw it up anything, and bowel and bladder habits were essentially normal. Coming to the examination findings, the general examination, there was no pallor, icterus, cyanosis, or lymph node enlargement. She had a hyperpigmented diffuse reddish violet rash on her face, especially in the periorbital area, chest, and limbs. She had aphthous ulcers in the mouth and a generalized spitting edema. There were nodules on her elbows and knees with surrounding erythematous rash, and the joints were normal. Anthropometry was essentially normal. The systemic examination. We did the CNS exam. I'll present the CNS examination first. The movements were restricted to pain. And she was pretty sick when she was admitted. So we did not subject her to much examination on admission. She was a little sick. Higher mental functions was within normal limits. Cranial nerves was within normal limits, and gag reflex was normal at that time. The motor system, the bulk of all muscles was normal, tone was normal, power was grade 4 in the muscles of the upper limb, grade 3 in the lower limb muscles. The reflexes were essentially normal, and sensory system was normal. There were no involuntary movements or cerebellar signs or any signs of meningeal irritation. The other systemic examination, respiratory system showed bilateral crepitations on auscultation, otherwise she was okay. Other systems examination was normal and joints were not involved. In summary, it was a 7-year-old girl child with a generalized photosensitive violaceous rash of 1 month duration with accompanying generalized edema and a symmetric weakness of proximal muscles which started 2 weeks into the illness. So we considered among the differential diagnosis, we considered juvenile dermatomyositis, SLE, and other connective tissue disorders. So these are images that we took during the first admission. So she had this rash and edema and was pretty sick, and she had aphthous ulcers in her mouth. She was bedridden. So the investigations showed hemoglobin hovered around 10 grams, except when she required ventilation and certain procedures during the second admission, where she became anemic, probably iatrogenic anemia, and she needed a blood transfusion. Otherwise, it hovered around 10 grams. Total count was essentially normal, except for high counts when she had some pneumonitic episodes. Differential count was neutrophilic, essentially neutrophilic during the entire course of treatment. ESR was high on admission. It was 76 millimeters in the first hour, and thereafter it came down to around 20 by 6 months after treatment. CPK was about 2000 on admission and came down to the 60s range after about 1 month. LDH was consistently high. It was in the 2000 range. SGP, that is, we did that for around a few months and it was consistently high. SGPT was around 150. We have a lot of values, so I've just condensed it into I'm just giving the range. We had a lot of values which were around 150. SGOT was somewhere above 100 units per liter. ANA was negative, so we repeated it and it was again negative. SSB was 4.2 units per ml. Anti-DS-DNA was 15 IU per ml. C-ANCA was 3. P-ANCA was 3.08 units per ml, normal being less than 6. HBV, HCV, HIV, and HSV tests were negative. TSH was within normal limits. RFT was normal, and electrolytes were within normal limits. Peripheral smear showed normochromic normocytic to hypochromic microcytic picture. USG abdomen was normal. Echocardiography was done, which was normal. HRCT, this is essentially when during the second admission it was done, and that showed bilateral chest infiltrates because she had aspiration pneumonitis in that second episode. Stool routine showed RBCs 3 to 5 per high power field. EMG and muscle biopsy, we opted not to do that as the child was pretty sick, and these are uncomfortable procedures, so it was not done. And we got certain consultations done. Most important one obviously was rheumatology consultation. And our rheumatologist, he started her on treatment for JDM with IVIG and methylprednisolone. We also got cardiology and neurology consultations done. Both were essentially normal, and the dermatology consultation was done for the rashes, and as per their advice, the local applications were done. We started her on physiotherapy. So the entire course of the illness, it took around 1.5 years. She had several episodes during that period. So starting with the first admission, which was in November 2018, we treated her as a case of JDM with acute lower respiratory infection, and she was sent home on steroids, methotrexate, and home physiotherapy. The second admission was about 1 month later after the first one. She had aspiration pneumonitis by then, and she was ventilated. She had one episode of generalized seizures while she was being weaned off the ventilator. She was started on anti-epileptics, and we ruled out meningoencephalitis with the CSF study. The MRI then showed post-ictal edema. And she was on mycophenolic acid and steroids for JDM by then. Continuing with the course, after 3 months after the second episode where she was really sick, and she went with these immunosuppressants, she came back to the OP. She came back actually only after 3 months. She didn't come for a review in between me actually. 3 months later, she walked into the OPD. And I was pretty surprised. She had a candy in her hand. She was beaming, and she had a very pretty dress on. I remember it now, even now. And the only thing that was remaining was some residual hyperpigmentation. She walked, but she was not walking totally normally, but she could walk. She was on her own, and only residual hyperpigmentation was visible. Then she had another admission, that is a third admission, 9 months after the first admission, that is in August 2019. And this was essentially, it didn't have much to do with the JDM. She had breakthrough seizures due to non-compliance with anti-epileptic drugs. We stabilized her and sent her home after 1 week of treatment. At that time, she was on methotrexate for JDM. And again, she had another admission, that is 1 year after the first admission, that was in December 2019, when she sustained a fracture of the left femur. And so a TED scaling was done by the orthopedician. The last consultation, actually, essentially, she didn't come to the pediatric OP. She came for ortho and rheumatology consultations, where she was apparently better. I didn't see her, so I really don't know how well she was at that time, but she was reviewed at the ortho and rheumatology OP. So that brings me to the end of the presentation. It took around 1.5 years, but she was better from what I gathered. Towards the end, she was better. Thank you.
Thank you so much, Dr. Preeti. It was an excellent presentation. It's a difficult case you handled with your rest of your consultants. I would now want Dr. Suma. Suma, can you share your slides, please? Suma is going to tell us about the difficulties with dealing with this particular problem in rheumatology. And she's, as you all know, I don't think she requires a formal introduction. She is the pediatric rheumatologist at Amrita Institute of Medical Sciences. She's been in the forefront of pediatric rheumatology, contributed to the IAP drug formulary, And Suma, your slide is not coming through.
Yeah. Now?
Yeah, it's come.
Yeah. Okay.
So Dr. Suma is going to talk, make it full screen, please, and put the first slide on.
Yeah.
Okay, so she's going to talk about the challenges faced in JDM. That is the JDM roller coaster. We're talking about the roller coaster because that is it's quite a prolonged illness that the children are going to have. Next slide, please. Biodata with that beautiful picture of yours. So, Suma is a professor of pediatric rheumatology at the American Institute of Medical Sciences, Kochi. She's MBBS from JIPMA Pondicherry, MD from JIPMA again, and MRCP Pediatrics from UK and CCST at UK. And she's been a great source of help for all of us in Kochi. And I'm sure she's going to deliver, she's going to tell us a lot of things about she has in her mind regarding this particular issue. Over to Suma.
Thank you, Jason. Thanks, Preeti. It's a very interesting case, and it really illustrates the kind of difficult journey that you can have with these patients quite often. So I'm just starting with what is probably a very clear case of JDM, a boy with a heliotrope rash, with Gottron's papules, but and he came with a proximal muscle weakness, elevated muscle enzymes. It wasn't difficult to make a diagnosis here. Now, but all cases are not like that. And so this juvenile idiopathic inflammatory myositis, that's the term that we use these days for a collection of inflammatory myositis that happen in children. JDM is the most common among these. The incidence is about 2.5 per million, so it's not an extremely common disease. And that is one of the problems that we face in the process of diagnosing and managing these children. And median age of onset between 5.7 to 6.9 years. However, 25% of these children present as toddlers, which is again another very difficult thing that we need to think about. For juvenile polymyositis is even rarer than dermatomyositis and tends to occur in slightly older children. And JDM again is more common in girls compared to boys. So the classification of idiopathic inflammatory myositis in childhood is the commonest you see is dermatomyositis. Then you can have overlap myositis, which is a mixture of connective tissue, various connective tissue disease with predominant myositis. And polymyositis is the next. Then there are some really rare, even rarer causes, like a case of dermatomyositis who doesn't have muscle involvement, only skin involvement, or if they can have only muscle disease and no skin is polymyositis. Only skin disease and no muscle involvement is amyopathic. And then there is focal myositis, orbital myositis, etc. So now, there are a whole range of skin lesions that you can see in juvenile dermatomyositis. And some of these lesions tend to show that it's active disease and some tend to show that it's chronic disease. So I think Gottron's heliotrope rash, the malar rash where you have the nasolabial fold involved, then the shawl sign where there is a rash on the shawl area of the body, a V sign. This all shows the photodermatitis aspect. Then non-sun exposed erythema can also be present, erythroderma, livedo reticularis, skin ulcers, then capillary loop changes, mechanics hands, so very, very hard, very over-cuticalized hands. Subcutaneous edema, generalized anasarca can be a presentation, and paniculitis can be a presentation. All these can be active skin disease. Calcinosis often indicates chronic disease or damage related. However, calcinosis can also indicate active disease. Lipoatrophy is one of the long-term problems that you can see and this is often a chronic disease. And most of the time, calcinosis, lipoatrophy represent disease that has been incompletely controlled in the early stage. A quick example. So we had this 2-year, 8-month-old child, so a little toddler. She came referred as a PUO. The referral diagnosis was possible, systemic onset JIA. She was having high-grade fever. She was a very irritable child, though she wasn't toxic. And the only history you could get out of the parents is that she's not as energetic as she used to be. About 6 months ago, she had some skin rashes, which was treated by homeopathy and had resolved. Everything in her general evaluation, all that was significant was an elevated LDH. Every other test was completely normal. So basically, she had normal peripheral smear. Now, in this scenario, the first thing you'd want not to miss out is a malignancy. So she underwent a bone marrow, especially with this elevated LDH. That was normal. But then, went back, re-examined, and then I thought, let's get an MRI thigh. And that gave us the answer. So you're having T2 hyperintensities, increased signals in all the muscles, and this is juvenile dermatomyositis. So this child had some skin disease, which homeopathy has masked. This child has only one muscle enzyme elevated in the lot, that is the LDH. So CPK can not always be elevated in patients, and that's something else that we need to know. We still need to think about the disease. It is not elevated. Maybe started her on treatment. She's done extremely well. So the clinical presentations that we can tend to see is a classical presentation, the first slide I showed you. Then they can present as pyrexia of unknown origin. I've had patients with pyrexia of unknown origin and a macrophage activation syndrome who have turned out to be JDM. They can be just an irritable toddler with variable cutaneous features. Again, in the young child with alopecia and progressive weakness. We've had a child like this, and the dermatologists were treating this child as a primary alopecia areata with pulses of steroids, which was not at all helpful because it was actually masking the problem. I think when a young child has a possible diagnosis of alopecia areata, they need to be evaluated first for connective tissue disease underlying in the first instance. A child who presents with persistently raised liver enzymes, don't always presume SGOT, SGPT only belong to the liver. They can very well be muscle enzymes. And a child who presents with anasarca, a non-nephrotic generalized edema, who may or may not have. Now, this child that Preeti presented luckily also had the typical skin features, but not every child tends to have the typical skin features. I've had 3 patients who just presented as anasarca, non-nephrotic edema. They also had hypertension and fever. And it was very interesting. It was the muscle enzymes that gave us the clue in these patients. And as we gave them high-dose steroids and started their treatment, the hypertension settled, even more interestingly. So it was a vasculitic manifestation. And then they can also present when they've not been treated well in the early stages, they can come back to you with complications. So the first time patients can present to you with contractures, calcinosis, lipodystrophy, metabolic syndrome, interstitial lung disease, etc. The differential diagnosis is a whole variety of neuromuscular diseases, myopathies, infective myositis, etc. And I'm not going to go into detail about that because it's usually self-explanatory. Now, we have diagnostic criteria. This is one condition in which we still actually respect the old Bohan and Peter diagnostic criteria coined in 1975. And this criteria basically spoke about the typical rash, the proximal symmetrical weakness of the muscles, the muscle biopsy changes, elevation of serum levels of muscle-associated enzymes. So there are 5 muscle-associated enzymes that we need to be checking out: CPK, LDH, aldolase, ALT, AST. Okay, so all 5 need to be checked in children because, as we said before, about 40% of children may be CPK negative, and you need to know which enzyme is actually raised in each child so that you know how to follow them up. Typical EMG changes are also present. And previously, you looked at all these features and you made a diagnosis of definite, probable, or possible JDM, depending on the number of things that were available. However, this necessitated needing to do quite painful conditions. Like Preeti said, EMG and muscle biopsy can be quite invasive and painful procedures to do. And we found better ways of diagnosing these children now. So now there is a whole lot of additional criteria: muscle MRI, nail fold capillaroscopy. And they have as much weightage as doing an EMG or a biopsy, calcinosis, dysphonia. These are all things that give us clue, in addition to the typical skin rash, proximal muscle weakness, and elevated muscle enzymes. In fact, ultrasound of the muscle in specialized units where they have the skill to look at it is also coming up in a big way as a diagnostic criterion um, for JDM. So these days, most patients, we don't do EMG and biopsy. When we suspect clinically that we might have a case of JDM, we do a muscle MRI and we look for all the other features. And that's the way we go ahead with these patients. However, making diagnosis is one thing. How do you monitor disease activity? How do you find out if your child is actually getting better? In the early stage, your muscle enzymes will help. But in the long term, muscle enzymes don't stay elevated that often. You can't rely on them to show you the question of a flare-up of disease. So that's why we have these assessment scales. There's a series of movements that you make the child do when you give allotted scores. These are validated scores. The childhood myositis assessment scale. This is the one I use most commonly, and it's a direct printout, thing from the web, and you can just make the child go through this, and you score this child every so often, and you can see the improvement in score. So it's a score out of 52, and very, very, very weak child could score below 8, which is a very, very which shows severe weakness. And as you treat them, you might find that they start. And there are so many uses to the score, when you can reduce your steroids, when you can think of stopping steroids. There's so many reasons to use the scores. What is a pathogenesis? The early JDM is a small vessel vasculitis. So most of the features will present like you see in a vasculitis, hence the rash, the edema, most of the findings that you tend to see in those cases, small vessel vasculitis, and is cytokine mediated. But later it becomes more of a vasculopathy in the long term, and which is interferon mediated. It's not the same disease in adults and children. And for this reason, I'm sorry, but I do have a bias about pediatric rheumatologists managing these patients. Children with juvenile idiopathic inflammatory myositis, particularly JDM, are far more likely to develop calcinosis than adult counterparts. Again, malignancy with JDM is very, very rare. In adults, any patient who turns up with polymyositis or dermatomyositis, they would be routinely screening for malignancy. We don't need to bother with that in children because the association is so extremely uncommon. Overall, JDM is a condition which has a far better prognosis in children compared to adults, but they need to be treated well as well to get this prognosis going. Now, the latest thing on the block with JDM is actually, can you hear me? It is actually myositis-specific autoantibodies. So now, this is something that is being researched in the last sort of 15 years, and the last few years, it has been widely available to us as well to check out. The prices were very expensive. The rates have slightly come down now. So these are a series of autoantibodies which actually help to tell you what clinical course these children could be taking. So some of these antibodies are what we call, they have different names in America and in Europe. So in Europe and England, anti-TIF1 is called P155 by P140 in America. So we'll just stick to the UK names now. So the anti-TIF1, the anti-NXP2, and the anti-MDA5 are the ones that we tend to see commonly. However, the one that has a best prognosis is anti-MI2. In adults, however, the commonest MSAs are tRNA synthetase and anti-MI2. So there is a significant difference in this. Itself tells us that the disease is not the same. Interstitial lung disease is less frequent in children compared to adults. It's a very devastating complication. However, it's the same myositis-specific antibody that tends to be associated with interstitial lung disease, both in adults and in children. There are many other systems that can be affected. So as we said, there can be fever and other systemic features at onset. Arthritis is a common problem alongside with 40% of children can have that. Pulmonary disease can be very severe and can be something that causes mortality, especially if they are in the anti-MDA5 phenotype. GI disease, so GI vasculopathy is quite common. And generally, children who present with edema are kind of presumed, edema, cutaneous ulcers, etc. They are presumed to have GI vasculopathy. And therefore, the idea is to try and use intravenous formulations or parenteral formulations of the medications until you see that edema subside and get better. And the most severe, but one of the most severe complications is cardiac. A JDM patient who presents with myocarditis or pulmonary hypertension is rare, but the mortality can be very, very high. And CNS is also very, very rare, but denotes severe disease. This child had seizures. It would have been interesting to see whether imaging was done, and we know why this child had seizures. So what are the investigations you do for these patients? We've been through most of this. It's just a little summary. So all the muscle enzymes must be done at diagnosis. So you know which enzymes are peaking in your particular child. Enzymes can be normal sometimes, particularly if it's a chronic presentation. As the months go by, the muscles do undergo atrophy, and they don't tend to, they don't tend to produce enzymes like the acutely inflamed muscle. So it's important that in the long term, when you see a patient with JDM, and just because their enzymes are normal, that does not mean they don't have active disease. MRI, looking at the stir sequences, particularly the T2 weighted sequence, is very, very useful. Ultrasound, if you are in a particularly specialized setup, where you have the expertise to do it, then ANA can be positive in many patients. It is not particularly going to point you to the diagnosis. Then we also do myositis specific and myositis associated antibodies. You can, myositis specific antibodies I've already explained. Myositis associated are like the SSA and SSB, which Preeti showed us that her patient had. Muscle biopsy, these days, we generally tend to do muscle biopsies when we have atypical cases. So either they have no skin changes or skin without muscle involvement, or they have a very atypical presentation. I had a toddler who presented with paniculitis and myositis, and that was a case in which I did a muscle biopsy. So we don't tend to do as many muscle biopsies these days as before. The other very important thing is that muscle biopsies they need very, very expert interpretation. There are very specific protocols in how to interpret muscle biopsies in JDM. And honestly speaking, our level of expertise in this matter overall in India itself is low. So I do find that I'm less inclined to do muscle biopsies unless absolutely essential. This is just a diagram. It's not a very good picture, but it's just showing you how muscle MSAs, the myositis specific antibodies, are helping us these days with recognizing clinical phenotypes in children. So this is your anti-TIF1 patient, and this patient has rash, proximal myopathy, and these are the patients who are prone to a generalized lipodystrophy and a metabolic syndrome in the long term. They often present with cutaneous ulcerations as well. And this is an anti-NXP2, and you can see that these patients are the ones who are more prone to calcinosis in the long term. And an anti-MDA5 are the ones who are more prone to lung disease in the long term. So these are all things that help us, again, to recognize clinical patterns and to also modify our treatment appropriately. So the initial diagnosis should also include assessment of the clinical severity of the patient and assessment of the possible phenotype, and thus allowing us to predict how the future might deal with this child. All these things are going to help us manage the patient appropriately. So The degree of muscle weakness, as I've indicated by the CMAS, one of the scales, is there pharyngeal muscle weakness, dysphagia, dysphonia? I would suspect that Preeti's case did have some degree of that if the child presented with aspiration pneumonia in the very first month. And this is something that we need to be really careful about. These are again patients who need very, very intensive treatment in the early phase. They probably need an NG tube till that the pharyngeal weakness is completely resolved. Otherwise, they are at risk for aspirations. Cutaneous ulcers are going to suggest to us that this is a more severe vasculopathy and these children are going to have more complications. So manage them much more aggressively in the beginning. Cardiopulmonary involvement is again a measure of severity. GI involvement is a measure of severity. And the children who present with severe edema are also in that stage likely to have quite severe disease. This is just a patient who presented with interstitial lung disease. You can see the CT and the X-rays, and this is a child whom we were able to treat beautifully. We treated very, very aggressively. This child had severe pulmonary hypertension and required sildenafil as well, in addition to all the treatments for interstitial lung disease. But we were able to reverse everything. This child was on home oxygen and sildenafil. Everything was reversed. She's now growing very normally on just her maintenance medication. So the complications are a severe systemic involvement, contractures which can actually represent both active disease as well as inadequate physiotherapy in the early stages, and a measure of poor disease control which leads to long-term contractures. Calcinosis also can represent both active disease and inadequate early aggressive control of JDM. Infections as part of aspiration, as a part of immunosuppression, something that we need to be vigilant about. We had a JDM child who presented with a GI perforation due to CMV colitis, not due to gut vasculitis. Drug toxicity, so steroid toxicity is something that we come across in these patients, and that can also present as muscle weakness. So we need to be able to differentiate that. Lipodystrophy and the metabolic syndrome in certain specific patients, it's very sad because this is something that is difficult to reverse. And early onset atherosclerosis, that's when you have prolonged inflammation, that's always going to be a problem. And these are all, calcinosis. You can have sheets of calcinosis. You can have just single large lesions. You can have multiple large lesions. And this boy presented with contractures, fixed flexion deformity, and multiple calcinosis. And we treated him quite aggressively. And his calcinotic lesions have reduced. His fixed flexion contractures have straightened out. And he's much, much better overall. And you can see this is all part of lipodystrophy. You can see here there's evidence of lipodystrophy, acanthosis nigricans, onset of metabolic syndrome in a child who's had the disease for a very, very long time. The prognosis, 25% of them have a monocyclic course. 25% of them, that means the disease comes once, you treat it, you get it under control, maintain the control, slowly taper, stop the medicine, and the child lives happily ever after without needing anything more. 25% have a polyphasic course, so it will keep recurring, and these patients need to be on therapy for a long period of time. 50% have a chronic course, which means it keeps staying active. Polyphasic will get better and it will recur again. And muscle atrophy, contractures, calcinosis, all these can cause a lot of difficulties to this child and the family. The mortality risk actually has come down. Before corticosteroids, the mortality in JDM was more than 30%. After corticosteroids, the mortality has come down below 30%. After we started adding in methotrexate, subcutaneous methotrexate at the onset of disease, the mortality has come down very, very, very significantly. And now there are far more things that we can do to improve the early treatment. So it is really important that these patients are appropriately assessed in the early stage of disease and the right treatment is planned for them. These are certain myositis-associated antibodies that can tell us that we can have more long-term problems than the others. And presence of pulmonary and cardiac disease is very important. We have two studies from from India. One is from Surjit Singh's team and one is from Raju's team. Raju's here with us today. I'm very proud because Raju's team, the first author, is actually currently doing DN rheumatology with us in Amrita. A very, very good student. And it's very nice to actually for me to be able to quote his article when I'm giving this talk. It is very clear that the diagnosis is significantly delayed. Median time to onset of diagnosis in Western Indian cohort was 7.1 months, and in the Northern group was actually 13 months. This led to very high rate of calcinosis, very high rate of cutaneous ulcers, very high rate of lipodystrophy. So it's really important that we take dermatomyositis seriously. We have to be wary about the atypical presentations. We have to be wary about the heterogeneity in presentation and the fact that muscle enzymes being normal should not take us away from the diagnosis. We have to be aware that delay in recognition and access and referral to an appropriate tertiary unit can actually affect the long-term prognosis for that particular child. The appropriately aggressive therapy at onset, and that is actually steroids plus or minus IVIG plus preferably subcutaneous methotrexate, not oral methotrexate, and the good dose. In certain children, we would elect to use cyclophosphamide at onset. In certain children, we would elect to use some other medications, but those are few. But more or less, most patients, we would start with high-dose steroids and subcutaneous methotrexate. And that is something that is very, very important to carry out very early in the disease, because if you see the study below, it has really shown the benefit of aggressive treatment of combining steroids with subcutaneous methotrexate early on in the disease in the complete and sustained remission in the long term. There can be expenses. However, this is a rare condition and it has to be managed appropriately. You can get very, very good results if you treat early and hit hard. And these days we are getting more and more targeted therapy driven by better prediction and diagnosis. I hope this was useful. I'll stop here and let Raju take over. Thank you.
Thank you so much. Thank you so much, Suma. And very, very comprehensive talk on this very, very difficult issue in pediatrics. Thank you. We'll have now Dr. Raju. Raju, please share your slides. Raju Kubchandani is also known to all of you, and many of you have come to just listen to Suma and Raju because they've been so much in the forefront of rheumatology in India. And we're happy to that Suma showed your series of JDM, which was published. Dr. Raju, can you share your slide? We're going to talk about complications and more about treatment of this difficult condition. Management 2020 is the topic. And can you full screen? It's not full screen as yet. No, it's not full screen. Raju, it's not full screen. Yeah. Next slide, please. And the next slide, please.
No, one moment. It's just gone dark. No. Yeah.
Yeah. No. The previous. You don't have your biodata slide. The next slide.
Yeah. Can you see?
Yeah.
Now?
Right. So Dr. Raju doesn't require, but for formality, we tell you that he's working in the SRCC Children's Hospital, Jaslock Breach and Breach Candy Hospitals. He is on 5 international consensus groups, plenty of publications, orations, research projects, 2 books and 8 chapters. He's a good sportsman. He's a table tennis junior national champion in 1972. Wow, that's great. Give a round of applause for that. Didn't know that. His passion is travel and teaching, and that's why he's very, very sought after faculty in most conferences. Here, we just wanted him to talk on this topic. He enjoys writing nonsense rhymes, which he'll say a few of them at the end of today, and swimming while listening to old Hindi songs is something of his passion. Over to you, Raju, for the topic.
Jason, I just want to first start by just doing a voice test. I
Yeah.
hope the volume is coming out right.
Very good. It's coming out very well.
So, while I stay back on this slide, I must make two very clear observations. The first thing is that I have to congratulate the organizers of specifically today's meet for selecting a topic like dermatomyositis. The problem is that in rheumatology, most of our diseases are called rare diseases. General pediatricians therefore believe that it's not really necessary to know about it because when are we going to see a case like this? But this actually leads to a little bit of a vicious cycle because what the mind does not know, the eye does not see. And I'm therefore glad that Kerala has taken the lead in making dermatomyositis the focus point of today's discussion. And this is the reason that I wish to congratulate the organizers of this series. The second thing, I really loved the way that Preeti presented her case and she was able to synopsize in 15 minutes what had happened in 15 months. And last but not the least, following Suma is not a very easy task. Suma gave an excellent overview, and it is obvious that we are going to have a little bit of overlap between what she spoke and what I spoke. But net result will be that you would go home with one common message. So let's start with this most fascinating story. And why I love to tell this story is that this child did one house job in Wadia Children's Hospital. He was there for more than 6 months. So he saw one whole rotation of all the resident doctors there. He was brought to me to Jaslok with a duration of illness that had been going on for 9 months. He had a nasal twang. He was brought in a stretcher. He had classic skin signs and he had contractures. Now, the skin signs, Suma has already spoken to you about, but note that he was brought on a stretcher. And it was a spot diagnosis. And one wondered and really felt sad as to why this story had been going on for 9 months. But please see some of these videos and the inspiring work by my physiotherapist Trupti, in addition to the various medical managements that he received. But at the end of this cloud, there was a very lovely silver lining, as you will see. Now, this is the child sometime in 2016. You see that he cannot extend his knee beyond this. So he has a flexion contracture of both his knees. He has a similar contracture with both his feet in plantar flexion. Now, the story moves on, and in 2016, you would find that maybe there are a few degrees more that are possible. He's able to extend his knees, maybe that little marginally more. Now look in 2017, what is happening to this child who was otherwise completely bedridden. He receives a pushback knee splint, and you see him walking on the left. And this is the child in January 2019 on the right. The major reason that I am making this presentation is don't give up on this disease. There is light at the end of the tunnel, and many of these patients do remarkably well. And I must tell you that the oldest patient with dermatomyositis I know, who I am still in somewhat touch with, is a boy who I saw in 1994 when he was about 6 years old. And today, therefore, he's 30 plus and doing extremely well. So these are some inspiring stories. And just as the way Suma mentioned in her last slide, that 25% have a monophasic course, what we like to usually tell parents is 1/3 monophasic, 1/3 polyphasic, and 1/3 chronic relapsing. But having gone through this case, let us now come to the meat of the matter. And the meat of the matter is, what is the scope of today's talk? First is the important principles of management. And then at the end of this, those of you in the crowd who have decided to pursue general pediatrics and not become rheumatologists will say, why am I listening to all this? Suppose I go to Kottayam or I go to Varkala and I start my practice. How is all this going to help me in any way? Because I can't do any of this. No, my friends, there's a lot that you can do, and therefore, please continue to listen. So what is our first goal of treatment? The first goal of treatment is minimize damage due to either drug or disease. And I love this quotation, which I like to use everywhere. Cured yesterday of my disease, I died last night of my physician. In that the disease gets well, but either iatrogeny or drug-related side effects are what create the problem for the child. So this is your entire menu card summarized. And if somebody wants to take a picture of this slide and create the entire building block around this, this is what we are going to be doing going forward. Photo protection, drug therapy with the menu that is visible in front of you, supplements, physiotherapy, as I just showed you a little while ago, can really play a very, very crucial role in the lives of these children. And I must tell you, these parents were farmers. They sold every utensil in their house. We supported them financially, and they came and lived in Bombay for 6 months exclusively for physio. Mental health and other educational issues, monitoring the child, activity monitoring, damage monitoring, and monitoring the skin, the muscles, and various organs. And last but not the least, monitoring drug adverse effects. So the first most important aspect where you are going to diverge when you are in the thick of these woods is identify the high risk patient. This high risk patient is a patient whose childhood myositis assessment score, which Suma referred to, is less than 15. Or there is another type of score called manual muscle testing, and that score is less than 30. A very young child, aspiration or dysphagia, and you saw that in Preeti Peter's case where the child got admitted with multiple pulmonary infiltrates, GI vasculitis, bloody stools, or you see GI vasculitis on imaging. Occasionally, like in the case of the child I showed you, perforation of the gut. Cardiac involvement is seen in about 10% of patients. And you may have a reduced ejection fraction, cardiac failure, and we have even seen children with ectopic beats, ventricular premature beats, notably. Parenchymal lung disease, CNS involvement. So this was, again, what Preeti Peter's case showed you, seizures, skin ulceration, and lastly, patients who, because of any of these situations, require ICU care. Now, when you start treatment in any patient with a rheumatologic disease, do understand that you're going to be immunosuppressing them. And he is not going to be a happy camper if he has latent tuberculosis or hepatitis viruses or HIV lurking somewhere in his body. So a pre-treatment infection screen is mandatory. Thyroid screening, for a reason I will tell you later. And if you do have that window of opportunity in that the child is not very acutely sick and you've made your diagnosis even on your first or second visit and you are waiting for all the tests to finish, please catch up on all his immunization, because otherwise it's going to be a very long time before which you will get a window of opportunity to give vaccines to this child. Notably, the live attenuated vaccines, because the child is going to be on immunosuppressive therapy, and even the killed vaccines may not act if the immunosuppressive therapy is in significant doses. Now, this is an algorithm that I have pulled out from an article in 2017, which was published by what is called the SHARE guidelines. And the SHARE guidelines have highlighted this as the current algorithm to treat patients with dermatomyositis, juvenile dermatomyositis. It is divided into two parts, part A and part B. Now, if you can look on the left upper corner of your slide, you see A. This and the next slide will be part A, because the algorithm was so big that I could not fit them into one slide. So this A part is going to spill over into a second slide, and then there will be two slides on the B part. So this is your patient who has non-severe disease. So what you're going to be doing is you're starting high-dose steroids, preferably a methylprednisolone pulse on 3 consecutive days, followed by oral prednisolone. And you will always start methotrexate in a dose at least 15 milligram per square meter, preferably subcutaneous. And you know the reason why subcutaneous? The reason is that these patients have a GI vasculopathy, and therefore there are concerns as to whether the drug will get absorbed well enough from the GI tract. Advise sun protection, adequate calcium, vitamin D intake, and then you keep reviewing the child regularly. And how you review the child, I will be coming to in a moment. And then you look whether there is improvement or not. If there is no improvement, then you got to check for adherence and tolerance to treatment. On the other hand, there is improvement, then you would obviously continue methotrexate and start weaning the steroids. But if there is intolerance to methotrexate, you could consider two alternatives, either mycophenolate mofetil or cyclosporin A. In my practice, I prefer mycophenolate mofetil. Cyclosporin A is a very fussy drug. You need a fair amount of monitoring, and cost-wise also, it's not particularly cheap. So this is my personal choice. Now we spill over table A to the next slide, and I've deliberately kept the top line the same as the bottom line of the previous slide to ensure continuity. You continue methotrexate if life is good, and if the patient has been on remission for a minimum of 1 year of steroids, you may decide to stop methotrexate. On the other hand, if the patient has not responded, then you are looking at intensifying treatment, in which case you add, you do not substitute, you add IVIG, one option, but a very expensive option, or you basically may consider adding cyclosporin A, mycophenolate, or very occasionally even a biologic like rituximab or a TNF blocker. And then you keep reviewing this patient. If he improves and there is good improvement, you go back and you start weaning off the steroids while you continue the other drugs. And then again, if life has been good for a year, you stop treatment. Basically, what we are doing is we are starting with pulses of steroids. We are starting methotrexate. Life is no better. You're going to add a second drug. At some point in time, if life becomes good, then you're going to slowly taper off the steroids. Once you stop the steroids, then you can continue the disease-modifying drug for a year more and then stop disease-modifying therapy. That's the crux of this story. Now, on the other hand, suppose you have a patient who has very severe disease, then you straight away start him on high-dose therapy. But this is a situation where you may have to consider cyclophosphamide, 500 to 1000 milligram per square meter IV monthly for 3 to 6 months. And alternately, you may intensify therapy using various other options. And again, the algorithm goes down the same way as the previous one, finally culminating in stopping therapy if the patient has been well and off steroids for a period of 1 year. So this is your basic plan of treatment. But how do you know whether life is improving or not? Therefore, there are various organ systems you have to follow. The first is the skin. In the skin, nail fold capillaroscopy is a very sensitive marker of activity. I used to be in great awe of it. Till last year, we decided to take the challenge and said we must master this story. And now we've got a grip on the whole thing and we do this as a routine in our day-to-day practice. Besides this, there are several visual tools, and there are cutaneous assessment tool, a disease activity score, a cutaneous dermatomyositis disease area and severity index, and myositis intention to treat activity index. Let this all stay as Greek and Latin as far as you are concerned, but just note that there are tools available to quantify skin activity. It is not good enough for a rheumatologist to say, are you better? No, I have to give some digit to it. So look at it as if you are doing a glycosylated hemoglobin in a patient with diabetes. So this is the same way we are trying to quantify assessment of the skin. The same way Suma said, you quantify assessment of the muscle. Now, the childhood myositis assessment scale is quite easy. And if you read the maneuvers, it's available free full text on the net. Let me tell you that it doesn't take more than 3 to 5 minutes to perform the entire story when the patient is on your bedside. And the myositis assessment scale not only measures strength, but also measures endurance. Both are relevant when you are assessing muscle. Muscle enzymes is something that already Suma spoke about. But remember one thing, that when you do an MRI, you ask for T2 weighted images and you see hyperintensities in the quadriceps. Remember one thing, that today, just the way Suma said, muscle biopsies are hardly ever asked for. But if for any reason you have to do a biopsy, then please do your MRI before the biopsy, because the needles there, or similarly the EMG needles, are likely to irritate the muscle and give you a false positive MRI. Remember also that tomorrow you start seeing a patient who's been on therapy for 12 weeks. His muscle weakness has improved and then gone back into trouble again. But his skin is cleaned out. What has happened? He now has steroid myopathy and not disease myopathy. And this is where, besides muscle enzymes, an MRI may be able to tell you the difference between disease myopathy and steroid myopathy. As yet, the best way to assess calcinosis remains manual palpation and plain radiographs. And comparing radiographs over time, CTs, etc., are very expensive on radiation and cost. So for the lungs, the moment you have an older child, you can do a DLCO to understand in interstitial lung disease the diffusion capacities. Chest X-rays do not come with very good sensitivity. You're to miss. And if there are features of ILD, then a CT. But more importantly, once you have got a patient with this, it may not be possible for you to do a lung function test at every visit or a CT at every visit. Therefore, whenever you are doing these, do them on the same day. That is number one, so that you know how the child looks anatomically and how the child looks physiologically, structure and function. And on that same day, do a 6-minute walk test. It's a very simple thing to do. You just need 50-meter distance and a stopwatch. That is all you require with a pulse oximeter, and you can do a 6-minute walk test and use this as a very simple screening tool every time the patient comes to your office. Cardiac assessment, Suma already told you about hypertension and the ECG and the 2D echo, and I told you about the 10% frequency of cardiomyopathy in these patients. Though I must say that while textbooks mention 10%, I now have a series of about maybe somewhere between 65 and 70 children with dermatomyositis, which is almost twice the number that we published a few years ago. But I can recall clearly just 2 children with cardiac disease in my setup. And I've always wondered as to whether dermatomyositis is a different disease in India versus in the West. Because when you speak with your Western counterparts, they will always paint a very grotesque picture of this illness, which I'm sure Suma will agree with me is something that we don't see so very often. Myositis autoantibodies, I will skip this slide because Suma already went into it at some length. It also becomes very important as a part of the management to monitor drugs. So when the patient is on methotrexate, you need to monitor the counts and the liver function tests. Cyclosporin requires blood pressure, potassium, creatinine, blood counts, and liver function tests. And therefore, I said that cyclosporin is a little bit of a fussy drug. I don't much use it. I won't say I don't use it at all, but it's my third choice over here. Mycophenolate is comparatively a safer drug. I've hardly ever seen any adverse effects with it. And of course, steroids is a different ballgame altogether. And entire talk can be spent on monitoring children who are on long-term steroid therapy. And the entire list is in front of you on the slide. What is very important is to identify when the patient is clinically inactive, because that is what is going to set your timeline as to when you can stop treatment. And there have to be fulfillment of 3 out of 4 variables. Your CPK has to be low. And here, I mean, well, I wasn't part of this Printo 2012 consensus group, but I can tell you one thing, that straight away, relying on the CPK alone doesn't make me very happy. I would say all muscle enzymes should be normal, because you'll notice that the CPK is the quickest to rise and the quickest to fall. It's that LDH which keeps lingering on and is one of the most stubborn enzymes to get back to normal. And aldolase is not easily available to perform. And the myositis assessment score, the MMT8, and PGA stands for Physical Global Activity. So this is a 10 centimeter scale you draw, and you put your finger on that scale as to where you believe the patient stands today and measure that. These are validated measures. So it's not somebody throwing a dart in the dark on the line and saying, this is where the patient belongs. And then last but not the least, you measure damage. So the difference between activity and damage is the activity tells you how is the fire burning, and damage tells you what are the ashes left behind. And for this, we therefore have a myositis damage index. And this is a very nice study that one of my DNB students did on myositis damage index, which we published, which we haven't yet published actually, but we showed at one of the conferences. So it's a very easy to perform story, but I would request Preeti to please incorporate this tool while managing her patient. Photo protection is extremely important. Using sunscreen on sun-exposed areas, sunscreen being with an SPF greater than 30. Remember, even on a cloudy day like you must be having in Kerala now, even between 10 and 4 in the morning, when the UV light is the maximum, this has to be enforced. Tight knitted clothes, wide brimmed hats, stockings, 6 feet distance from screen and tube lights is the way to go. While the patient is on steroids, it's a good idea to restrict sodium. And of course, hygienic food is a very non-specific term, I must say. But what we are trying to say is, as far as possible, this child has to be kept sheltered from infections to the maximum possible. And the reason to restrict sodium is to minimize water retention and weight gain while on steroid therapy. Recall the videos when I speak about exercise and physio. And remember one thing, writing a prescription for a chronic disease is one story. But answering the parents, you ask Dr. Preeti Peter, who has now got this first-hand 15-month experience. Writing the prescription probably took her only 3 minutes. But her parents, the parents of the child, definitely asked her, how long will this treatment last? Will my child die? How expensive are my drugs? I'm not insured. What is the course of this disease going forward? Will these pigments and scars remain? Will I be able to go to school? Can my child go and play football? Which games should he select on the other hand? What careers will he be able to pursue? Do you think if she's 17 years old, the child, will she get married? Will she be able to have children? And then you realize the relevance and importance of educating the child and the family. Giving them your prescription alone is not the answer. You need to give them your time. And therefore, coming to the second part of my talk, which I will go very quickly, what is the role of the general pediatrician in this whole story? First off, cultivate a pediatric rheumatologist in your geography. And you have somebody like Suma, who's absolutely available within maybe a 3 or 4 hour region. And I am telling you that the pediatric rheumatologist would add a lot of value to managing your patients without you losing the patient. And how you would do that is available to you in the next few slides. So when Suma sends you a prescription like this, Then you immediately start saying, okay, this is the steroid. What is its action? What is its side effect? This is naproxen. Now, this is a sample prescription of a child with JIA, but just to understand what is its action, what is its side effect. This is methotrexate. What is its role? What is its side effect? These are all the supplements and to avoid side effects of other drugs. So, insist on the parents reporting after each visit to the specialist. It is your right and duty to know what the subspecialist advised at the last visit so that you are completely on the ball. Treat intercurrent illnesses, but use your Epocrates app. The patient may be on 2 drugs or 3 drugs. You choose to write a 4th drug. Please check that there are no drug interactions. Identify warning signals, pardon the spelling error on identity, and alert the specialist straight away. Monitor the growth. This child is on steroids. There's a chronic illness. There are 2 reasons for this happening. Immunization, hygiene, diet, lifestyle. All these advices can be supplemented by you. Monitor the adherence of the drug therapy. Know one thing, that you knew the family many, many more years earlier than you referred the child to Suma. So therefore, you are in a much greater position to be advising them what they should be doing. Offer them psychosocial support. Communicate with the specialist. Above all, clear myths and misconceptions. Where you are today, your biggest competitor is your Ayurvedic massage parlor. Okay? Please tell them that they have no role to play. Alternative systems of medicine. And then ask them to differentiate between homeopathy and sympathy, and then decide where they wish to go. Above all, this child is going to turn 18, at which point Suma may suddenly say, I don't see children above 18 years. There is a fair chance that this child may still be having some residual disease and may have to make a transition. And remember, transition is not an event. Transition is a process. At 18 years and 1 month, you tell the patient, now you please see the adult rheumatologist. And Suma has been seeing the child for 3 years. They are not going to be happy campers. So this is another story where you can come in. Last but not the least, therefore, for all these kind of things, you cannot see these kind of patients while you are seeing 100 patients with URI and diarrhea. So you have to create a slot in your practice where you protect time for all such chronic care, whether it be epilepsy, growth hormone, thyroid, cystic fibrosis, you name the illness, it is important, and you will do a great service to yourself and perhaps allow yourself the opportunity to make a mid-career change like I did when the bug of rheumatology bit me when I was 45 years old to shift over to rheumatology. Last but not the least, you also have a community responsibility. Maybe you will be called to liaise with the school to create a general awareness about the disease and maybe even help in some fundraising events. So friends, you are the pillars to chronic care of these children. But these pillars have to stand on a foundation, and that foundation has to be built by the pediatric rheumatologist. Thank you very much for a patient listening.
Thank you, Raju, for a the clarity of thought. The clarity is what is so important in all your talks. And Suma and Raju have given a really very good exposition of their thoughts on juvenile rheumatoid arthritis. Now, there are certain questions. The first to Suma is, which is the better? Is it MMF or what is the second line drug that you choose?
Well, first line, as I think both of us have said, we go for methotrexate and subcutaneous methotrexate. And depending, it all depends on clinical presentation. So if you have very, very severe disease, then your first line might be the possible. If you have, your patient is responded to methotrexate initially, but only partially, and you need to add it, I prefer to use mycophenolate. It's a very simple drug, taken orally, works very well, and has very, very few problems. The only problem is that it is a little bit more expensive. Azathioprine is a drug I do not find useful in children with dermatomyositis as compared to some other conditions where we use it in. It is something you can think of in those who are really cash strapped, and because azathioprine is much cheaper than cyclosporin or mycophenolate. The other option is if, some of the medical colleges have supported me with some poor patients by giving them monthly IVIG for a few months. So that has also been something to resort to when you needed a bit of extra push.
Dr. Raju, there's a question. What is the life expectancy of a child with JDM?
So let me say to you that if you pray that I am going to be 85 years of age, I will give you that answer when I'm 85. As I mentioned to you, in my personal experience, I have lost only one patient with juvenile dermatomyositis. And this one patient had a very rapidly progressive interstitial lung disease. Otherwise, so far, of all the 65 or 70 patients I talked to you about, there has been no loss of patients so far. And I don't think any of them are really even looking as if they are in a situation where there is a life threat to them. Now, this is something where we would have to revisit series of patients who have transitioned into the older age group. But I must tell you a major flaw with those kind of studies. And that flaw is that, our biggest hero, that is methotrexate, is only about 15 or 18 years old in the game. And that has been a game changer for several patients with various rheumatologic diseases. So therefore, if you saw a patient who was diagnosed in 1990 with dermatomyositis, and you saw a patient who was diagnosed in 2010 with dermatomyositis, I'm sure that their morbidity, mortality statistics will be different. So this is about the answer I can give you right now. I don't know if Suma is able to provide any more very specific digits on this.
You said that there's some difference between the type of disease in the West and here.
Yes. So,
because in the West, they say life expectancy, there's a life-threatening disease.
So this is exactly where, we saw the difference. And, realistically speaking, Suma was very kind enough to show 2 series of Surjit and myself over here. And I do wish and hope that Pranav is also around somewhere and listening to this. He's really one of my most favorite postgrads, extremely sincere boy, and he had done this analysis. And actually, there is a third study from Lucknow. And if you look at all these 3 studies, and if you try and combine it to make some sort of a meta-analysis loosely, if you may allow me to call it so, not meeting all the criteria, what was the unique finding of all the Indian population was that 70% of them had a monocyclic course. And therefore, personally, I have always felt that if on a Monday morning, I have to see a patient with some chronic disease walk into my office, and it is between a systemic JIA, a lupus, and a JDM, I will select JDM any day. I don't know what Suma's choice would be.
Okay, the next question to Suma is: are these children, they can the PWD Act, the Disability Act, do they get provisions and do they get drugs through them?
Well, to be honest, I think the monocyclic JDM patients, and in fact, many of the JDM patients, if you treat them aggressively in the beginning, they hopefully don't need to be with the PWD Act. It's probably the group of patients who develop complications despite treatment who are going to need. I do have one patient who's wheelchair dependent years into the illness, and that's because she came to me 7 years after the illness had started and she had not been on adequate therapy at all. She's the girl who had the sheets of calcinosis, the x-ray put up. And we are still in the process of convincing the family to have surgery now and go through an extensive physiotherapeutic process, because they also develop severe osteoporosis. And that's another problem to tackle when you're going to be doing all this remobilization with physiotherapy. Now, so I would say that, yes, I think they have definite deficits. Yes, they will they will get help from the PWD Act. But I think we should try. There's a lot we can do to prevent them from actually having long-term disabilities. If we treat them aggressively in the beginning, then I think a good number of them, you will find that you can prevent most of the long-term disabilities that you see. These days, wheelchair-bound JDM is a very rare event, actually, compared to what used to be much earlier.
Great news. See, this article from which we got this Rollercoaster thing was the article in Pediatric Rheumatology 2019, being on the JDM Rollercoaster qualitative study in which they checked with adolescents who were suffering from JDM and made them draw. I don't know if you've seen that article where they said, I want this to stop. I could not move. I always feel sad. I've seen so many doctors. I was anxious what was going to happen next. I hate the way I look. And they called a term called steroidal. I feel steroidal. I feel scared. The fear of methotrexate injections. And therefore, is psychiatric help something that you really need to give these children?
Definitely. I think when children are needle phobic, when children are not inclined to be compliant with their medications, when they find any difficulties with their condition, the treatment required, etc., a good number of them do need some psychosocial help. And we are fortunate to have a good psychological team to help us. Methotrexate subcut is not so much a problem as methotrexate oral. You will find later on when you change them, oral methotrexate seems to have much more of this anticipatory nausea and dislike to the drug as compared to the subcutaneous one, which is strangely tolerated better.
Dr. Raju, is JDM a form of lupus?
Is JDM a form of?
Lupus.
No. They are two separate connective tissue diseases. They're two entirely different. So I would say that if you have to classify connective tissue disorders, then this is one of the ANA positive connective tissue disorders, with the difference that in lupus, ANA is invariably positive. In dermatomyositis, the positivity rate of ANA is not so high. Suma mentioned 80%, but to my reading somewhere, it was somewhere between 40 and 60%. But I could be wrong. And to complete the list, the other ANA positive connective tissue diseases are scleroderma and Sjogren's syndrome. So this would complete the list of ANA positive diseases that you should know about. ANA, and therefore the short answer is JDM and lupus are two different diseases belonging to the same family.
Thank you. Shall we go on to the quiz, Suma? Can you share your slide and you have the slide? No.
You have them?
You have them, or should I
Yeah,
share it?
you can share them. You want me to read
You,
them?
yeah, you'll read them and go through the. First, we'll as you go along, the answers will be put in the chat box,
At the end.
and the Johnny will be marking the answers. Okay, and I think the Pramod will be putting the. So if you answer question 1, the answer should be in A, B, C, D. A1, A1B, 1 should be mentioned as such. 1A, 1B, whatever your answer is. Okay, the first question.
So which of the following skin changes is not associated with juvenile dermatomyositis? A. Heliotrope rash. B. Malar rash. C. Gottron's papules. D. Evanescent rash. And E. Shawl sign. Next question.
10 seconds. Is that okay?
Yeah, next one. The difference between idiopathic inflammatory myopathies in adults and children are all except childhood IIM has better prognosis, increased association with malignancy in childhood, increased likelihood of calcinosis in children, polymyositis is rare in childhood IIM, increased incidence of interstitial lung disease in children compared to adults. Three, Bohan and Peter diagnostic criteria for JDM comprise all except typical skin changes, heliotrope, Gottron's papules, proximal muscle weakness, elevated muscle enzymes, muscle MRI showing edema and inflammation, muscle biopsy showing perifascicular atrophy. For all of the following are muscle enzymes except A, CPK, B, lactate dehydrogenase, C, gamma glutamyl transferase, D, aspartate aminotransferase, E, aldolase. In a patient with IIM, normal muscle enzyme levels suggest all except clinical improvement, amyopathic JDM, chronic JDM, steroid toxicity, and early disease flare. The interpretation of myositis-specific antibodies in IIM in children, which one is wrong? Anti-MI2 has the best long-term prognosis. Anti-TIF1 is associated with severe cutaneous disease and lipodystrophy. Anti-MDA5 is associated with severe interstitial lung disease. Anti-dsDNA is associated with cutaneous ulcers. Anti-NXP2 is associated with calcinosis. Of the following, the least likely recognized complication of JDM is aspiration pneumonia, gastrointestinal bleeding, cardiac arrhythmias, muscle atrophy, and skin calcifications. All the following are recommended as part of the non-pharmacological treatment program in JDM, except physical therapy, occupational therapy, avoidance of sun exposure, bed rest, social and psychological support.
Okay, now Suma, you'll go through the answers.
Yeah. So in this one, there is a clear D is the wrong answer. Evanescent rash is not something you see in JDM at all. And here, the difference between idiopathic inflammatory myopathies, I just realized that there are actually two right answers here. So anyone who has given B or E has got the right answer. It's not associated, there's no increased association with malignancy in childhood. In fact, there is hardly known any association with malignancy in childhood. And incidence of interstitial lung disease is higher in adults compared to children. So B and E can receive marks here. And 3, here it is. Bohan and Peter classification did not have MRI. So muscle MRI showing edema and inflammation was not part of that classification. It's a very old classification. It has been revised to the subsequent classification where muscle MRI makes an appearance. So D is the correct answer. All the following are muscle enzymes except gamma glutamyl transferase. That is not a muscle-derived enzyme.
Liver.
C. And then, in a patient with IIM, normal muscle enzyme levels suggest all except early disease flare. You would expect that in early disease flare, you would actually have high levels of muscle enzymes. When there is clinical improvement, enzyme levels can come to normal. A myopathic JDM suggests that the muscle inflammation is not there in these patients. Chronic JDM, as I explained before, they may stop actually elevating the muscle enzyme levels despite active disease. And steroid toxicity also, you do not expect them to have elevated muscle enzyme levels. So, yeah.
Yeah, want to say something more?
Yeah, so E is the correct answer. Here, the interpretation of myositis-specific antibodies, the answer is it doesn't matter whether you listen to anything I said about myositis-associated antibody. The thing here is that anti-dsDNA is not a myositis-specific antibody. It is it's a red herring here. So that's D is the right answer. And the least likely recognized complication, as Raju kept on saying, is actually cardiac arrhythmias, C. And here, D is the right answer. We never advocate bed rest in these children, never. We want them, even when they are very sick, very weak, we want the joints, we want the muscles to be mobilized, even at rest. So that D is the right answer.
Thank you, Suma. Now, what is the, Johnny, could you tell us who's the winner?
Dr. Arvind. Dr. Arvind is the winner for today's quiz. He's got the highest score.
Where is he
Dr.
from? Arvind won yesterday's last time also. Is it from Tamil Nadu? Arvind, can you show yourself? Arvind, in the chat box, can you?
Dr. Arvind.
Can we have the winner on board, please?